Hello, my name is Tahmina Mustafa, and I am professor in global health at Center for International Health, University of Bergen. In this lecture, I am going to talk about chest X-ray to detect pulmonary tuberculosis, strength and weaknesses. And the chest X-ray is useful for diagnosing tuberculosis disease because pulmonary tuberculosis is the most common form of disease. The introduction of radiography as a diagnostic tool was a landmark in our knowledge of the natural history of tuberculosis and its diagnosis. It is therefore no wonder that the enthusiasm with which chest radiography was received and applied sometimes caused the method to be overrated. It is still widely believed that pulmonary tuberculosis can be diagnosed by chest radiography alone. However, practical experiences and many studies have shown that no radiographic pattern is diagnostic of TB. Many diseases of the lung show a similar radiographic appearance and can easily mimic tuberculosis. Similarly, the lesions of pulmonary tuberculosis can take almost any form on radiographic picture. So therefore, in this lecture, you are going to learn about how does chest X-ray contributes towards TB diagnosis, what are the strengths and weaknesses of this modality as a diagnostic tool, and to become familiar with the common radiological patterns of pulmonary TB. Chest X-ray is a good tool, but it should be used as a diagnostic aid and not as a confirmatory test. It is a good test actually to rule out the possibility of TB disease or active TB in those who have a positive test for TB infection, namely they are positive with MAN2 test or the new IGRA test, and they have no signs and symptoms. It can also help us in diagnosing disease in those who have symptoms suggestive of TB. Therefore, this test is quite sensitive. That means it's a very good test to pick up most cases with active TB disease, but it is not very specific. That means that in the presence of a lesion on an X-ray or a finding on an X-ray, you cannot say for sure that this is really TB or this is some other disease. Now let's see how could chest X-ray be used in the diagnosis of tuberculosis. In patients who do not present with signs and symptoms of a serious level of illness, namely those who are considered ambulatory, or in those who are HIV negative with non-severe illness, the evaluations may be managed along a somewhat different path. If the smears are negative and the initial clinical evaluation deems a diagnosis of TB unlikely, it is reasonable to give treatment for alternative diagnosis more time and fully assess the responses before considering a re-evaluation for TB. If there is no improvement after treatment with broad-spectrum antimicrobials, patient should be assessed again, and here the chest X-ray could help ruling out TB if X-ray does not show any pathology. However, there are lesions on X-ray that would warrant further confirmation by culture. Chest X-ray alone cannot confirm the presence of TB disease, as many other diseases mimic the same radiological picture. In a study where 132 patients with negative sputum smears and who had chest radiographs consistent with tuberculosis, and thereby who would have been treated with this strategy for TB, among them 47% actually had smear and culture negative sputum tests, namely that they did not have TB. Therefore, X-ray tended to overdiagnose these cases. Therefore, obtaining cultures can be of key importance, particularly in smear negative suspects who are not responding to empiric non-TB interventions. Let's see what are the common features of TB on a chest X-ray. Usually, when a person has TB disease in the lungs, the chest X-ray usually appears abnormal. It may show infiltrates, which is produced because of collection of fluids and cells in the tissues of the lung, or cavities, which are hollow spaces within the lung that may contain many tubercle bacilli. These X-ray pictures from the posterior anterior view and side view show extensive pulmonary infiltrates on the apical parts of both lungs. These findings are consistent with TB. However, pneumonias caused by other pathogenic bacteria could also present with a very similar picture. This is another X-ray showing a multifocal patchy opacities in the right upper lobe of the lung. This is also an image of the pulmonary TB, which could be shared by other types of pneumonias and therefore not confirmatory for TB. This picture on right shows an X-ray with thick-walled cavity in the right upper lobe of the lung. The illustration on the left shows a cartoon of the lung with cavities produced due to the tissue destruction caused by Mycobacterium tuberculosis. The presence of cavities supports a diagnosis of TB. However, atypical mycobacteria can also present with similar radiological picture. Here is another example of TB radiology. This posterior anterior chest radiograph in a young patient shows a right upper lobe and right lower lobe consolidation and a small pleural effusion on the right side caused by TB. Again, these features could be shared by other pneumonias. This X-ray shows what happens when a cavity is filled with fluid, which is usually pus. Again, this feature could be caused by other causes of lung abscesses and not just TB. And sometimes lung cancers, they also present with similar air fluid level picture on chest X-ray. This is miliary tuberculosis in an adult woman. She was also sputum smear positive for acid-fast bacilli, a usually rare finding in this type of tuberculosis. The reason for the sputum smear positivity is because of the cavitary lesion in the right upper lobe marked by the black arrow here, which is draining directly into a bronchus, as it can be clearly visualized by the air bronchogram. Again, this is another example of chest X-ray finding in pulmonary tuberculosis. There is a cavitary opacity in the right upper lobe shown by the arrow, prominent paratracheal area on the right indicating enlarged lymph nodes, and a focal consolidation in the middle lung zone on the right side. Here, the presence of cavitary lesion would support the TB diagnosis strongly. This is a portion of the radiograph from a child showing the left upper part of the lungs and a part of the hilum. And the picture is of miliary tuberculosis and shows clearly a hilar lymph node, which is typical for tuberculosis resulting from recently acquired infection. It is also possible to see radiographic findings as a result of prior active tuberculosis disease, namely sequela of the earlier tuberculosis disease. We have to note that age and activity of the disease cannot be determined by a single chest X-ray. Here, the top X-ray shows a calcified granuloma and a hilar lymph node calcification shown by the arrows. Generally, this kind of combination is known as Ranke's complex, and this shows the primary tuberculosis infection. And the lower left shows the apical pleural thickening, and the lower right shows the apical fibrosis with some volume loss. Findings from large trials done during the mass screening of populations for tuberculosis by chest X-ray showed extensive inter- and intra-observer variation in chest film interpretation among highly trained and experienced radiologists and chest physicians in the decades before HIV-associated tuberculosis. These studies showed that on average, 32% of the chest X-rays showing lesions were missed to be diagnosed as TB cases, namely the readers read the lesions as not caused by TB. This was true even if the experts read X-ray as shown in the top row, where 5 experts missed approximately 25% of the positive films. Interestingly, when the same films were read again after about 3 months, the experts changed their mind in about one-fifth of the cases they had previously classified as positive, and this shows an intra-individual inconsistency of 20%. Several studies shown here confirmed that about 26 to 39% of the films might be underread. For example, a Danish group consisting of 3 experienced readers examined 5,000 unselected small films independently. On average, underreading occurred in 32% of cases and overreading in only 2%. These observations were later confirmed in the United Kingdom. In another large study in the USA on the usefulness of periodic chest radiograph screening, small chest x-rays were taken of each of the 15,000 first-year university students. The films were read by a panel of 50 readers composed of equal numbers of radiologists and chest specialists. According to a randomization scheme, each reader provided 3,000 readings, thus ensuring 10 independent readings of each film. Students whose films were interpreted as positive by one or more readers were further examined by spectrology, tuberculin test, and tomography, and followed for the duration of their stay at the university. Ultimately, 249 films were classified as definitely positive by a small group of Empire readers who had access to all the necessary information. Now, after this extensive examination, the level of underreading by the whole panel of 50 readers was on average 39% of the 249 definitely positive films. Conversely, only 1.2% of the films were overread. When only the results of the 10 best readers, including 5 radiologists and 5 chest specialists, were considered, the rates of underreading and overreading were appreciably lower, but still unsatisfactorily high. Comorbidity with HIV infection and tuberculosis further diminishes the reliability of chest radiography for the diagnosis of pulmonary TB. Since the emergence of HIV/AIDS, clinical studies have consistently documented the atypical radiographic patterns seen in patients with both pulmonary TB and HIV. Hilar or mediastinal adenopathy, middle or lower lung field infiltrates, and absence of pulmonary infiltrates and cavities are common in such patients, as are normal and minimally abnormal chest radiographs. In summary, the experience of many decades of detailed data collection and analysis indicate that chest radiography for diagnosis or follow-up of pulmonary TB cases with or without HIV co-infection is unreliable. Furthermore, there are several operational challenges associated with chest radiography. The method requires availability of equipment, a continuous supply of electricity, high quality supplies, technically competent processing, reading, and interpretation of films, which might be difficult to achieve at the peripheral healthcare facilities in low resource settings. Furthermore, to obtain a high quality film which is neither overexposed or underexposed is not as easy. WHO has published a handbook for district hospitals in resource constrained settings on quality assurance of chest radiography for better TB control and health system strengthening. So in summary, chest X-ray alone cannot confirm tuberculosis disease. Other diseases can cause lung abnormalities, which look very much similar to abnormalities caused by tuberculosis, and only bacteriological confirmation can prove that patients have TB disease. And chest X-ray may appear unusual or even appear normal for persons living with HIV. And as many as 15% of patients living with primary tuberculosis have normal chest radiographic findings. However, this test is quite useful in ruling out tuberculosis rather than ruling in TB disease.